Welcome to the Nursing Post podcast, All Nursing All the Time with Ashley Moore and Rosa Horsley. In this episode, we discuss healthcare in America. Our goal is always to inform, help, and start conversation.
We're about to put a spotlight on disparities, wanting to educate anyone that we can in the inequality in our healthcare system. You cannot fix what you do not know is broken. With COVID in the news all the time, disparities are now at the forefront, and we can no longer turn a blind eye and choose to believe it doesn't exist.
So why do disparities exist? I think to understand that, we need to clarify what a disparity is. And according to dictionary.com, it means a lack of similarity or equality. So something that's unequal or a difference between two things. And in this case, we're discussing the inequalities of healthcare.
Right.
Secondly, we know some of the reasons that inequality exists. The high cost of healthcare, inadequate, inaccessible, and unequal healthcare treatment for racial and ethnic groups. The economic gap between the rich and the poor grows wider by the day.
And these aren't just our thoughts.
It's statistical. It's proven facts.
This is proven facts. So that's kind of one of the big things that we want to get into is some statistics that actually back that last paragraph.
Yeah. Or this whole podcast.
Yes, this whole episode, exactly. So premature death, and that's before age 75, from stroke and coronary heart disease were higher among blacks than whites.
Which we talked about on our last podcast.
Yes, with the hypertension and stroke, correct. And rates for drug-induced deaths were highest among American Indians or Alaskan Natives and Caucasians. This is one that hits us a little bit close to home. Tuberculosis cases are declining among all racial and ethnic minority groups, which is great. However, they are still higher among racial and ethnic minorities. And that was in 2010.
It's crazy to me.
Yes. And from 2007 to 2010, obesity has increased significantly, and that it's more leaning towards boys versus girls. Of course, the same racial and ethnic disparities persist with obesity as well.
So minority women, except for Asian Pacific Islanders, with less education, who speak a language besides English and have a disability, were more likely to report fair or poor self-rated health. I think that's big.
Right.
That's a disparity all in of itself.
And they recognize it. They're recognizing that their health is not well managed.
It's not up to par. And then during 1999 through 2008, life expectancy, free of activity limitations caused by your chronic conditions, they were significantly greater for females than for males, and greater for whites than for blacks.
Right. Which I don't understand that.
I wonder what their disability or limitation is.
Right. So there wasn't anything for me to expand on when I did the research for that. I did look. Preventable hospitalization rates were higher for residents of a lower income compared with higher income neighborhoods, which of course that makes sense. The lower your income,
the harder it is to access health care.
Right.
How can you afford it?
And they may not, and that's maybe why they're using the ED as primary care.
Absolutely. Which we see around here a lot in
We do.
our area. Non-Asian minorities continue to experience higher rates of HIV diagnoses than whites. Compared with whites, a lower percentage of blacks diagnosed with HIV were prescribed antiviral therapies, and a lower percentage of both blacks and Hispanics had suppressed viral loads. That's huge.
That's big, because that's decreasing that viral load means you're at less risk for transmitting it. So I think that that's just amazing. We need to make sure that everybody who is HIV positive is on those antivirals and that they're treated to the T.
Absolutely.
During 2006 to 2010, preterm birth rates for black infants declined 8% to the lowest ever reported 17%. So
high.
that's great, when you read that first. But even with that decline, it's still 60% higher than whites or Asian or Pacific Islanders. So you're looking at still a huge gap there for white and Asian or Pacific Islanders. You're looking at about a little over 10% versus 17% for blacks. That's a big jump.
Well,
and
the mortality rate for black women was more than double than white women in both 2005 and 2008. So it leaves you wondering if it's lack of healthcare access to your prenatal visits, or if some underlying chronic condition was already there that made it a higher risk pregnancy or a preterm delivery.
Well, it makes sense if blacks are more prone to hypertension and diabetes within a pregnancy that can lead to a disaster. And this was our whole last podcast. The rate of blood pressure control among adults with hypertension were lowest among Mexican Americans, people without insurance, and those who never been married, and those born outside the United States. So if you're born in the United States, if you're married, have health insurance, why would you have a higher rate of blood pressure?
Yeah, I don't know.
Maybe
it's stress. It is. And some of it's untreated, which we'll talk about.
Yes, at a later date.
Put a pin in it.
So, access to health care. This is kind of a little subtopic on its own, but kind of keeping with the statistics a little bit. 2010, close to 65% of the U.S. population from age 50 to 75 met the U.S. Preventative Service Task Force criteria for up-to-date colorectal cancer screenings. And so screenings have increased with age, education level, and household income, which we know. And screening varied by insurance status, race, and ethnicity. There is still a gap there, which that's the whole reason we're talking today, is because of the gap.
And how to close it. We know it exists, but how do we close it?
Right.
And during 2010, approximately 2 out of 5 Hispanic adults and 1 in every 4 black adults were classified as uninsured. So that's a big problem right there in our gap. In 2010, the uninsured rate for adults aged 18 to 34 years old was approximately double the uninsured rate for adults aged 45 to 64 years old.
Right. And I wonder if that is because they're young and they feel like they don't need health care, or is it by the time they get to 45 to 64, they're using some kind of government assistance like Medicare, they've been disabled or something like that.
Well, how many times have patients come into the office and we ask if they have a PCP? And a lot of them say no.
Or I have one. I saw them about 4 years ago. That doesn't count. And then influenza vaccination coverage for children increased from the 2009-2010 year to the 2010-2011 season. So over that course of a year. And then among adults over the age of 65, it's also increased for Hispanics, but decreased for whites.
I'm so interested to know why.
So
it is. We finally get the news out there. We're finally vaccinating.
And the kids are doing good. The Hispanics are doing good. The whites are going down, and I'm assuming because nothing else was mentioned, they're holding steady.
Yes. The U.S. has one of the largest income-based health disparities in the world. Poor people in the U.S. were also more likely than rich people to say they couldn't get access to care because of the cost of it.
Right.
And they were more likely to report being dissatisfied with their last visit to the doctor.
Well, there's no resolution if they can't have the testing or get the medication,
Or you're trying to cramp all that care into one visit, and it's just not possible, especially if you come in, if you've waited. Let's say, okay, these are all the things I'm going to talk to the doctor about, and you go in with this list of issues for a 30-minute tops appointment. there's no way that physician can treat all your symptoms without having further testing.
Right. And most offices, I mean, they're scheduling patients every 10 to 15 minutes. Mm-hmm. And now some are even limiting the amount of complaints you can have per visit. And there's a catch-22 with that. They come in to actually see you, but you have to pretty much pick what are we taking care of today? Then you have to come back, and if they can't afford the copays, the transportation, take the time off from work, whatever the issue is, it kind of puts them in a bad situation.
2/3 of Americans report that many people in their country can't access the health care they need. That's 10 percentage points higher than any other country. Mm-hmm. So here again, we know it's an issue. Yes. We know people do not have adequate access to health care. So I feel like, why are we doing studies about the same thing, giving the same and worsening statistics instead of spending the money and the research to fix the problem?
Right. Kind of goes back to the vaccines with autism. We keep having studies to show that there's no link, but despite how many studies it shows, we're still doing the same ones over and over. And these things cost a lot of money. So the U.S. has also ranked near the highest in income-based disparities. So 1 in every 5 people in the bottom 1/3 of income report skipping medical treatment due to cost.
They just can't afford it.
So the bottom 1/3, 1 out of 5 can't seek adequate medical treatment. On the flip side, in the top 1/3, only 1 out of 25 skipped medical treatment due to cost.
I mean, it's a big deal. If you are in a group of 25 people, that one person out of the 1/3 top tier is the only person who's missed an appointment, who just said,
I can't go.
Budget. I'll wait until next time.
Right.
But then that's 5 people in the room on the bottom end, the bottom 1/3, who didn't get treatment, and it's probably not by choice.
And then the conditions start compounding and causing worsening problems.
The American Journal of Public Health study indicates that household spending on healthcare is a significant contributor to income inequalities in the United States. It also indicates that medical expenses pushed millions of Americans below the poverty line. So you were barely making ends meet, and then you had a medical crisis.
Yes.
And now those bills have pushed you below being able to make ends meet.
That's a lot of people.
It is. That includes 7 million people who make more than 150% of the poverty level.
Which isn't a lot of money. It sounds like a lot, but when you start doing the math, it's not. The poverty level is pretty low.
Yes.
And so when you start calculating that number, it doesn't really give you a lot to live off of when you have kids and all these other expenses.
4 million of those Americans are pushed into the ranks of extreme poverty.
If you take into account what we just said with all of the different disparities, there's one big thing that you can come up with, and that is if you are Black or any other minority. And most of the time, if you're a woman, you're not getting adequate care. There's another thing that you can actually put on top of that, and that's if you live in a rural county.
Absolutely.
Because people who live in rural areas are less likely to have health insurance. And rural Americans make up 15 to 20% of the population in the United States. And they face inequalities that result in worse health care than that of the minorities that live in urban and suburban populations.
Well, let's think about it. Rural.
Yes.
Basically is in the middle of the boonies, for lack of better translation.
Yep.
It's basically a hospital or a doctor's office secluded in the middle of nowhere.
Right. So then what happens is we have doctors who are already in short supply. And then those primary care doctors are stretched so thin, and the specialists are a rarity that they're trying to be the primary care doctor and the PCP.
They're trying to treat everything.
And when people don't have the means to get where they're going because maybe it's a really long drive, I'm not talking like 20, 30 miles. I am talking like
Hours.
100, 200 miles to get to a facility that can treat most of your needs. That means when these patients present, instead of being found with stage 1, stage 2 cancer, they're already metastatic. Or instead of getting their diabetes treated or even finding out that they have diabetes, they don't find out until they're having end organ damage and having much worse issues.
Compared with urban areas, rural populations have lower median household incomes and a higher percentage of children living in poverty, fewer adults with post-secondary educations, and more uninsured residents under the age of 65 with higher mortality rates. And that goes back to what you said. By the time they figure out what's wrong, it's too late.
And according to the U.S. Department of Veteran Affairs, 25% of U.S. veterans live in rural areas, compared with 36% of urban military veterans.
This makes sense to me because I grew up in a military family.
Right.
And my father lived on the island. And jobs are scarce. The island's small. It has poverty-stricken areas. And the only way for him to have a way to feed his family, you know, a roof over his head, medical insurance was to join the military.
Right.
And sometimes that's the only way out for some people.
And in the most recent U.S. Census, which is what these statistics are from, is from the census. We won't have more up-to-date stuff until this census is completed. Right. But that showed that rural diversity has been increasing. So whites make up about 80% of the rural population, but only 25% of the growth in a rural population was from whites. So the growth is coming from Hispanics. Really, they had a 45% increase. And then, so that's about equal to African Americans.
The largest growing minority group in America.
Right. So that really, and they're going to these rural areas. And so the disparity conundrum.
Yeah, it just keeps getting
continues.
bigger and bigger. The gap keeps getting wider and wider.
Right.
So Native Americans increased by 8%, and the number of Asians rose to about 37%, although remaining a small part of the total rural population.
And then, of course, twice as many youth smoke in rural areas versus their urban peers. Here you have all the tobacco-related diseases and mortality to tack on
top of
the inadequate health care.
The CDC also cites opioid overdose deaths as 45% higher in rural areas. And from 2008 to 2014, rural communities saw an increase of infants born with neonatal abstinence syndrome. So they were born with withdrawal, going through, DTs. And that's a condition related to maternal opioid use.
Yes.
And that was about 2.5 times higher than in urban areas.
That's so sad.
So with all these statistics and all these disparities, and with the recent pandemic, there's been a lot of news making headlines, waves.
Oh, absolutely. One from the Washington Post, and the title was, "The Cure for Racial Disparities in Healthcare is Known. It's the Willing to Fix that is Lagging." And I think it explains disparities really well. It's a short read, but more people are acknowledging the inequalities in our healthcare system. However, in my opinion, it's going to take leadership from the top down to really help educate those who are most impacted by the inequalities and the glaring disparities. And what I think is going to have to happen is it's going to take funding from the government. And then that funding will allow organizations to go out to these areas that need more education, better food, fixing the salary gap, all those things, because we know the less money you make, the less educated you are, the worse your healthcare is. So if we get them educated, making more money to where they can afford their treatments, they're going to get better care.
Absolutely. They're not going to be that 1 in 5 that skip out on an appointment because they can't afford it.
Right. Well, and that's what I hope. But part of me, and I mentioned this in the last podcast, had wondered if maybe there's just bias. There's just racial bias that we're not accounting for. And I actually found an article called "Implicit Bias and Racial Disparities in Healthcare." and it was put out by the American Bar Association. And this article states that despite having the same past medical history, diagnosis, timing to the hospital, insurance, income, all that was relatively equal, that blacks are still not getting the same care as their white peers.
This might be shocking for some people, but I think I have to pause because I know it's gone on since the beginning of time. I just think now it's more in the spotlight and in the limelight because the disparities in the middle of this pandemic have hit the fan, and there's no way of covering your eyes and looking away anymore.
No. And the idea that there's unconscious bias held by healthcare professionals, in my opinion, could explain some of these racial disparities. Of course, when I guess this was semi looked at, not really deep, because I really haven't heard a lot about it, and I was surprised to find this article. It was saying that providers aren't stating that they're having any of these racial bias. And for the most part, you would think if somebody's educated that the incidence of racial profiling decreases.
You would think. But it's ingrained in some people's upbringing, and it's hard to distinguish something that you've known all your life, even though you may not feel or think you're being that way. I think it's hard for some people to realize that.
Right. But taking a good hard look at it, really making sure that you're not making those racial biased decisions in healthcare is maybe a good start that doesn't cost anything.
No, self-reflection
is free.
It's free.
And it may fix a huge amount of problems that we're having, because I would think that if you go up to a physician and says, hey, you had these 2 cases and you treat them differently, why? And they can't tell you why, and then you go, well, this one was white, this one was black, and I'm sure the first thing they're going to say is, well, that doesn't matter. Well, maybe it does.
But maybe way back there it does. So Latinos are the fastest growing group in the U.S. and are affected by access to health care. And I was reading an article in Forbes, Latinos and Hispanics poised to transform U.S. healthcare system with 1.7 trillion purchasing power. So that basically means that you have a whole demographic here that can wield a lot of power if you know how to tap into it and shorten or make the gap smaller.
Right.
So because of immigration challenges, financial limitations, language barriers, and societal marginalization, many Latinos are completely alienated from the U.S. healthcare system. Estimates suggest that 1/3 of Latinos and Hispanics have had no previous access to healthcare services, and that issuing them insurance or an insurance card will not help.
Yeah, it doesn't fix the problem.
It doesn't make the problem any less. Because of language and cultural dissimilarities between hospital leadership, providers, and patients, most facilities and systems do not know how to properly approach the Latino population.
Which is just crazy to me. Like, if you have a question, ask somebody. Just ask somebody. I don't understand why that's hard. We can ask them all these questions in healthcare, but we can't say, what is your primary language?
It's just one more question. It's just one more question in the triage.
I just don't understand what the big deal is with that.
I don't get it. Fewer than 4% of healthcare providers speak Spanish, with Texas, New Mexico, and Florida having the highest percentages of Spanish-speaking providers. And these are single digits.
Yes.
These are not big numbers. Texas, 9%. New Mexico, 8%. Florida, 6%. Where's some of the largest demographics of Latinos?
That's exactly what I was about to say. I mean, that they are saturated in that area. There should be, I would say, at least 25% of the population down there who can fluently speak Spanish who is not Latino.
Just even having a translator, let's say, I'm not going to hold it against every provider that can't speak a foreign language. That's not
hire
fair.
somebody who can.
But exactly, I know you have access to some translators, and
Right.
this isn't even. I'm not even talking about just the the Latino demographic. We have people in this country that speak other languages besides Spanish.
Right.
And translators need to be made available to everyone, including the deaf.
Yes.
Vital for our country's health leaders. It's super vital and important that these providers and policymakers think critically about the particular challenges and opportunities that Latino and Hispanic patients introduce into the system, as well as prepare for better ways to serve their wants and needs. So we know Latinos on average are younger and have larger families.
Yes.
In 2014, PricewaterhouseCoopers reported more Hispanics than non-Hispanics use social media, mobile apps, internet searches to find information about their doctors and insurance companies, and that Hispanics are more likely to be influenced by the information when making decisions about care and insurance plans.
So there's a really big question here.
You have a modem. You have a way to reach this demographic, and we're failing.
And again, it's free.
It's free.
We're still free. We're not even expensive here. So self-reflection and use social media.
Now, I'm not going to lie. I'm a little slow with the social media. But apparently, other people are not. And so we're not using...
You're the 1%.
I'm the 1%.
You're the 1%.
I'm the 1% that can't use social media correctly.
I'm there with you. I'm there with you.
It's a little embarrassing. But we have a whole demographic that does know how to use it.
Yes.
And we're not tapping into it. And this is the question. Why aren't we using this information to bridge this gap, to make it smaller? Their culture and values and needs should be incorporated into service.
Yes.
When they call and make an appointment or try to attempt to make an appointment and they speak a different language other than English, we should be asking them if they need a translator.
Automatically. Don't wait for them to ask because maybe they're embarrassed or don't want to.
Or maybe somebody else is calling for them because they can't understand English.
And you're supposed to offer that in healthcare free of charge to the patient.
Exactly.
Well, I do believe that this can be fixed and that it will be fixed. The problem is while we're waiting for people to fix it, people are dying.
Yeah.
Yep. They're dying, literally. And as healthcare workers, I think that it's our job to care for the person in front of us. That patient is our primary responsibility.
Absolutely.
And the only way to really think of race or ethnicity would be when it needs to help with diagnostic. For example, sickle cell is predominantly a disease found in African Americans. That's relevant.
It is.
And when you have that information, use it for what it's relevant for, but don't treat the patient differently because they're Black or Hispanic or Asian or whatever.
Yes.
And
we should be treating the person, not the race, not the culture, not the religion, the person. We will link our references to our website, www.thenursingpostpodcast.com, and be sure to subscribe to our podcast. And as always, you can follow us on Facebook, Twitter, Instagram, and YouTube. Thanks for listening to The Nursing Post.